Welcome to Alterations of the Digestive System. Today we will be explaining the core pathophysiology of these exemplars: hepatitis, cirrhosis, pancreatitis, cholecystitis, ulcerative colitis, diverticulitis, and we will be identifying key clinical manifestations and diagnostic findings of each one. So let's get started with hepatitis. Hepatitis is liver inflammation, and it can be caused by viruses, alcohol, drugs, and it can even be autoimmune. There are multiple types of hepatitis, but A, B, and C are the most prevalent. So, for example, hepatitis A has a fecal oral transmission. This is usually the one that if it's tied to food, like sometimes restaurants will have outbreaks. Not something we want to think about. Um, it only has an acute course, so it just makes people acutely ill, and it is something that there's a vaccine for. Hep B is one that I know all of you have, and if not, you have an exemption because it is required for healthcare providers. It's transmitted via blood and body fluids. It can be acute or chronic. And then Hep C is the one that I think most people think of hepatitis as being only Hep C, and that is bloodborne transmission. And it is usually chronic. There is no vaccine for it, but luckily it is treatable now. So we'll discuss more of that a little later in the lecture. The pathophysiology of hepatitis. So basically, whether hepatitis comes from a viral, an autoimmune, or a drug-induced source, what it does is it causes the body's immune system to attack infected or damaged hepatocytes, which we remember are the functional unit of the liver. Those are those liver cells. When that occurs, cytotoxic T cells and different inflammatory mediators come in. They target those infected cells to eliminate the virus. But when they're trying to eliminate that virus, they actually end up damaging and destroying those hepatocytes. So, as that goes on, that cell injury and inflammation cycle leads to impaired liver function, causes the liver to swell, and it causes cell death, which we know is called necrosis or apoptosis. There is a problem with bilirubin metabolism, and that causes the jaundice that is seen. Um, so we might have discussed this a bit in our last lecture, but when a hepatocyte is working normally, it can take bilirubin and it can make it water soluble, which is a process called conjugation. And then it gets excreted into the bile, leaves through the digestive system. But when those liver cells are damaged, like with hepatitis, that process stops working. So all of that bilirubin builds up, and that leads to jaundice. And we see that as yellow skin and yellow whites of the sclera in the eyes. And that's a reflection that somebody's liver is not working properly. Um, so, of course, I think a lot of you have probably heard of or seen a baby who has jaundice, and that is because their liver isn't mature enough to excrete that bilirubin yet. And if it's really pronounced, then the baby will have to get treatment under those little billy lights to process that bilirubin out. But it's a little bit different with hepatitis, but it's all jaundice. AST stands for aspartate aminotransferase, and ALT stands for alanine aminotransferase. And they are enzymes, and they normally are in a hepatocyte. But when a hepatocyte dies, then those enzymes leak out into the bloodstream where they shouldn't be. So anytime that someone like a provider is curious if somebody has liver damage, they're going to look at liver enzymes, and they're talking about AST and ALT because they're a good marker of if there is hepatocellular injury going on. ALT is a little more specific to the liver, but AST can come from muscle and other tissues. But if they both are really elevated, that's a clear sign that somebody has acute hepatitis. So the liver also synthesizes clotting factors 2, 7, 9, and 10, and prothrombin when there is dysfunction in the cells of the liver, the hepatocytes. They can't synthesize these, and that is going to increase bleeding risk. So that is why we check. It's called a prothrombin, a PTINR. That's a reflection of telling us like how long somebody's blood takes to clot. Vitamin K, which we talked about the large intestine's role with that, but the liver has a role with that as well because it's a fat soluble vitamin. It can't be metabolized. And so that is definitely going to make somebody a bleeding risk. So, clinical manifestations of hepatitis, and I am really talking about um, I'm talking about acute hepatitis mainly. It's going to cause somebody to be fatigued, malaise. They're just not going to want to do much. And that is due to um, the release of cytokines. And the hypothalamus gets affected as well due to that release. And then that makes somebody lose their appetite. They're tired, just very low energy. And then let's also not forget that the liver plays a part in storing nutrients, specifically glycogen. And if that is not working properly, or it's not being released properly, that's going to contribute to that low energy. So the right upper quadrant pain, once again, the liver is that huge organ. It's in the right upper quadrant of your abdomen. It's enclosed by something called a Glisson's capsule that has the sensory pain fibers. So when inflammation occurs, the liver is going to get pretty swollen. It's going to stretch that capsule, and that's going to result in pain. When the liver can't detoxify the body properly, then metabolites are going to build up, and that's going to cause a lot of abdominal symptoms like nausea, not wanting to eat, and vomiting. Um, you will see dark urine because when the bilirubin can't be cleared from the body and it can't be conjugated, it's just going to spill into the blood and it's going to be excreted by the kidney. So the urine could be extra dark. Um, Now, the bilirubin is what makes poop brown, basically. So if it's not flowing through the bile to the intestines, then it's not going to be there and you're going to see pale stools. So seeing really light colored, like whitish poop is always a sign that something is not right. So that's a huge danger sign. We can have acute or chronic hepatitis. Acute means it lasts 6 months or less, and that is usually caused by hepatitis A or a toxic injury such as an acetaminophen overdose. Um, an I think there's been a little bit of attention given to Tylenol, and of course, acetamin is something that people can try to sadly intentionally overdose on. But also, it's really important to look at the medications that you're prescribed and your patients are prescribed and what you're taking over the counter because acetaminophen can be contained in a lot of things and it's not always really obvious. And even going over the recommended amount of Tylenol by a little bit, which I think is like 2,000 milligrams a day for an adult, is really toxic for your liver. So it's not just a benign medication. Now, chronic is when there is inflammation and necrosis of the liver that is going on for over 6 months. So that is more often caused by hepatitis B, C, or D, which we didn't really talk much about D, or an autoimmune hepatitis, or long-term toxin exposures like alcohol or drugs. So I think most people know that alcohol is really hard on a liver. So chronic hepatitis, you can see this little illustrated flow diagram. Um, we're not going to get into the hepatocellular carcinoma part, but you can see the picture of the healthy liver and then what it looks like when chronic hepatitis develops. And then we'll look into cirrhosis here in just a minute. Chronic hepatitis is when there is a persistent viral infection or immune activity, and there is ongoing injury to those hepatocytes. And then fibrosis happens. So that scar tissue and that scar formation occurs. And we say the loss of normal architecture occurs. So the liver just doesn't really have like its proper shape anymore. Um, so that over time can progress to cirrhosis, which we're going to talk about shortly, and liver cancer, which is hepatocellular carcinoma. The liver is very, very, very good at healing itself until it's not. It will put up with a lot for a long time, but when it's done, and the consequences are pretty dire. Um, so eventually, with chronic hepatitis, the liver is trying to make new hepatocytes, it's trying to regenerate, but that chronic inflammation just is going faster than it can keep up with. So that structural distortion occurs. Chronic hepatitis can be asymptomatic or just super vague abdominal symptoms or feeling kind of tired. I mean, whose stomach doesn't hurt every now and then? And, most people are tired. Um, but quite often, people have absolutely no symptoms with chronic hepatitis. There was not testing with it for a long time. And there are a lot of people who probably died of other things, like never knowing that they had hepatitis C. Hepatitis C is bloodborne, and prior to HIV coming along, we just didn't really have any, we didn't have um, standard protections. Nurses weren't wearing gloves. We weren't protecting against bloodborne transmission the way we are now because we just weren't aware of it. So, cirrhosis is that next step, as that little flow chart showed. This is when fibrosis is irreversible. So there's no coming back from this. Um, Nodules develop and they really disrupt liver function and blood flow. And then that progresses to end stage liver disease. So the most common causes of cirrhosis are chronic hepatitis and alcohol. And alcohol, I would say, is the biggest cause of this. So, cirrhosis pathophysiology looks like that chronic inflammation leading to the scar tissue, and then something called portal hypertension develops. So, portal hypertension is a little different than I'm not talking about systemic hypertension that happens in the whole body. So the liver has a portal vein, and under normal circumstances, that portal vein carries that nutrient-rich blood from the intestines, the spleen, and the pancreas. And when the liver is healthy, blood flows easily through these tiny little capillaries into the hepatic veins and then to the inferior vena cava of the heart. So the normal pressure in the portal system is about 5 to 10 millimeters of mercury. And I'm not going to ask a question for that, but just about those specific numbers, but just to put it in perspective. Um, in cirrhosis, we have those structural changes that occur due to fibrosis, and those little sinusoids where the blood usually flows really easily, it gets compressed. So blood can't flow freely through the liver, and then there is increased resistance. So that can lead to a lot of symptoms that I'll get to here shortly. We have reduced synthetic function. So also, the liver helps synthesize called something called albumin, which is a plasma protein that basically helps fluid stay where it needs to stay in the body. And that's why people get these big abdomens with cirrhosis and with liver disease because their fluid is collecting in the extracellular spaces. And it's why we give people with liver disease albumin. Like I said, we don't have the clotting factors the way we should. Something called ammonia builds up. So that's very poisonous. And it literally poisons the brain, and that is called encephalopathy. So that is called hepatic encephalopathy when somebody has encephalopathy from this liver process. So um, the portal hypertension leads to something called varices. So varices, you can see these little reddened areas on there. That's a picture of the esophagus. They're these weakened area of the tissues, and they're extremely dangerous because this area of the body is highly vascular, so a lot of blood flow, very weakened areas. So when that pressure is too high, it doesn't take much, and one of those can just burst open. And it's one of the most I will say it's one of the most disturbing things I've ever seen. I've seen it on a couple occasions. These are patients I'm honestly kind of nervous to take care of who have esophageal varices, especially when they're nauseous, because it doesn't take much pressure for one of those varices to just burst open, and then they will vomit out most of their blood volume within minutes. And it's always been fatal when I've seen it. There's not been any coming back from it. The low albumin, as I said, leads to ascites, and that high ammonia leads to confusion. So these are what some of the manifestations of cirrhosis look like. We have sparse body hair, um, a fibrotic liver. I haven't really noticed the red palms as much, but that ascites is a big thing. So you can see that stomach is distended. And even if the patient is male, it almost looks like a pregnant abdomen. It is just so taut. Um, and it feels like it's going, like you can touch it and it just feels like it's going to burst. There's so much pressure. Um, Not only will somebody have jaundice, which is that yellow skin, they also have the medical term for it is pruritus. So just extremely, extremely itchy. And that is because the liver can't metabolize all of these toxins and the bile salts. So they build up in the skin. So people with cirrhosis, advanced liver disease and cirrhosis, they're just extremely itchy because it's right there on their skin. They have spider angiomas. So these extra tiny little blood vessels. muscle wasting. And like I said, that confusion, it's very unmistakable when they get this progressed. Here are some different diagnostic tests that we do. It lays out all the blood tests and what they look like. I just want you to have a general idea of this and what they are and what they look at. Um, an ultrasound is often used when somebody has hepatitis or cirrhosis. It's a good way to look at the liver, see if there is fat accumulation, any tumors, any bile duct obstruction. We want to get viral serologies to identify the specific hepatitis virus. We look at ammonia levels and we look at a urinalysis to see if there's bilirubin in there. So the treatment of acute hepatitis, and so this is usually like a lot of times just a couple days stay in a hospital. It's supportive care. It's usually just resting and getting fluids, maybe some IV fluids, eating a balanced diet, and they just monitor the patient's liver enzymes. Um, when it comes to acute liver failure, like somebody is very confused, very jaundiced. All of these labs are out of whack. We have to manage the encephalopathy, the coagulopathy, and the fluid and electrolyte balance. So that looks like giving something called lactulose, which is this like lovely delicious syrup drink. It's not delicious at all. That patients with hepatic encephalopathy have to drink several times a day because it will bind with the ammonia and then they can poop it out. So you actually want them to be having basically several episodes of very soft stools a day to know that this ammonia is being eliminated. We can give blood products if we need to, and we can give albumin to address the coagulopathy. And we watch the fluid and electrolyte balance very closely. Um, it's really important to educate our patients with hepatitis, particularly if we know that they got it through substance use, such as needle sharing or using other sharing other equipments that people use to take drugs. There is also sexual transmission. It's not as likely, but it is possible. And also people who are getting tattoos that are not from reputable places, or somebody's, cousin is just pulling out their like little tattoo machine and they're not swapping out supplies between people. That's all a recipe to get hepatitis. So we want to educate about not sharing needles and making sure that if we're getting tattoos that we're getting them from reputable places. The treatment of chronic hepatitis is going to look like suppressing viral replication. So for hepatitis C, there are direct acting antivirals, and there's a 95% cure rate. It is important with our patients who have hepatitis C, when they do go through the process to take treatment for it, it's important that we educate them that they can still get hepatitis C again. It's not one of those things like a one and done. If you go out and you resume the same behaviors that gave you hepatitis C in the first place, you will recontract it. Um, so that is the main goal, and also reducing inflammation fibrosis. So really important that they avoid alcohol, any medications that are going to be toxic to the liver, that they maintain a healthy weight because fat likes to gather on the liver as well, and that can be a hugely hepatotoxic. And then treat metabolic syndrome because remember, metabolic syndrome is all about that fat accumulating on the liver. For somebody with ascites, they would have a sodium restriction and perhaps diuretic. When it's really out of hand, they will do something called a paracentesis, where they actually put a big needle into somebody's abdomen and they drain that fluid off into bottles. And that's just kind of like a temporary um, comfort thing because it'll usually fill right back up again. Um, let's see. They need to be eating a high carb, moderate protein diet. We don't want them eating too much protein because ammonia can be a byproduct of that. So we don't want them to be ingesting things that would be putting a lot of stress on the liver to digest. And supplement vitamins A, D, E, and K. Um, Ultimately, chronic hepatitis and cirrhosis can proceed to cancer. So it's important that they have an ultrasound to screen for hepatic cancer. Um, if things, get really advanced and they really get past any point of their liver healing itself, they will need a liver transplant. So that is definitive treatment. But, sadly, a lot of people die before they can receive a liver transplant. So moving on to pancreatitis. This is inflammation of the pancreas. There are acute or chronic forms. I'll be focusing more on the acute form today. And this is autodigestion of the pancreatic tissue. So, just a refresher, our pancreas is sitting there right behind our belly button. And typically, people get their pain when they have pancreatitis is centered right in that area. So pancreatitis can be caused by gallstones because the gallbladder sits right there. Um, Alcohol use disorder, hypertriglyceridemia, certain medications like steroids or thiazides, or trauma or post ERCP, which is a diagnostic test where they look at the abdomen. So sometimes just them poking around in there gets pancreatitis stirred up. The pathophysiology of pancreatitis looks like, well, normally the pancreas has digestive enzymes, amylase, lipase, and trypsin, but they're inactive. So they're not kicking into gear until we need them to kick into gear in the small intestine. And then once they're there, under normal circumstances, they digest fats, proteins, and carbohydrates. With pancreatitis, if something makes those enzymes activate too early, such as a gallstone, alcohol, or a duct obstruction, then those little digestive enzymes are going to start digesting pancreatic tissue instead um, of doing what they're supposed to do and waiting for the intestine. So the key enzyme is trypsin, and it becomes active and it just starts this cascade of activating all these other enzymes. Um, this whole process leads to inflammation, hemorrhage, um, inflammation, hemorrhage, and then tissue can even become necrotic. When the cells are damaged, they release inflammatory mediators. So there's those cytokines again, and they just make the process worse. Um, and then this inflammatory response can even go beyond the pancreas, and it can lead to a systemic inflammatory response syndrome. So this is super, super painful. And they can even become what's called hypovolemic, so not enough fluid in the body. And that is because that inflammation damages the blood vessels and allows the fluid and the plasma and the enzymes to leak out through the capillaries. Um, so they will often have a lot of abdominal pain, tachycardic, so a high heart rate from um, lacking the fluid in their body. And they can also have low calcium, which we call hypocalcemia. And that is because lipase breaks down from fat in and around the pancreas, and that releases free fatty acids. Then they join up with the calcium in the blood and they become insoluble calcium soaps. So once they become those calcium soaps, which is called saponification, that calcium's trapped and the serum calcium levels drop. And this is just a really bad sign when somebody has acute pancreatitis. So, clinical manifestations of pancreatitis, it is super, super, super severe epigastric pain radiating to the back. Um, like I said, it's usually around the belly button. There's nausea and vomiting. There can be a fever and an elevated heart rate. And there will be abdominal guarding, which is where somebody is just kind of like covering their abdomen and like protecting it, like, don't touch me there. And then there's something called the Cullen sign and the Gray Turner sign. The Cullen sign is that bruising above the umbilicus, and the Gray Turner sign is on a person's lower back. And that is only with the hemorrhagic form of pancreatitis. And I'm going to admit to you, I have heard of these signs a lot in textbooks and studying for the NCLEX and my NP licensing exam. I have not seen it in person. So, a little bit about the pathophysiology behind this is that the pancreas is just very inflamed. It gets very swollen, and it too has a capsule like that glistens capsule with the liver, and it stretches and it irritates the surrounding sensory nerves. And that pancreatic inflammation just extends into the back. So somebody will also have back pain as well. One way you can tell that it's pancreatitis is it gets worse when somebody is laying flat because that inflamed pancreas is pressing against those nerves. But it gets better when somebody is leaning forward because it takes the pressure off. The nausea and vomiting occurs because the pancreas is so close to the stomach and the duodenum. And when the pancreatic enzymes are released, and the inflammatory mediators are released, then it just irritates both of those. Um, so people usually are just vomiting and vomiting and vomiting, and they get no relief from it. And it is really important that somebody be nothing by mouth when they have pancreatitis. And I remember when I was in nursing school, I learned that um, it's best to not even bring food around them, and not just because you don't want to make them sad, but digestion really starts with even just smelling food. So even just smelling food could kick off more of those digestive enzymes and put them into even more pain. Amylase and lipase will be elevated. White blood cells and glucose will be elevated. Calcium will be low, and a CT scan will show the inflammation and necrosis. So the treatment is being nothing by mouth. They might need an NG tube if their stomach needs to be decompressed by removing gastric secretions, and that would reduce the nausea and vomiting. IV fluids, pain control. They'll usually be getting opiate medications, monitoring electrolytes. And also, if it was alcohol that triggered this, then they will need some education on that. So, alcohol can also be a big trigger for pancreatitis. Not always. So try not to stereotype every person you meet with pancreatitis as being a drinker, but it is often the case. So cholecystitis, that is gallbladder inflammation. And basically, the bile that should be flowing through is not flowing as it should. It's static, it's not moving. Um, so, what is happening is that a gallstone or even thick bile sludge, and yes, that is the medical term they use, blocks the cystic duct. And so, that cystic duct normally allows bile to go from the gallbladder into the common bile duct and the small intestine. So, when that gets blocked, the bile gets trapped in the gallbladder, and then the pressure increases, and that bile can really irritate the mucosal lining. So that bile stasis is usually the number one cause of cholecystitis. So then you can have infection occur, and that is called a secondary infection because it's not like the number one cause, but it can develop because that bile just sitting there, you never just want stuff just sitting around. Especially not bodily fluids, because it's a really ideal environment for bacteria. And the common organisms are E. coli, Klebsiella, and Enterococcus. And when the infection occurs, then pus can form, the patient can develop a fever, elevated white blood cells, and systemic infection. Um, the impaired fat digestion, so the big function of bile is breaking down fats. With cholecystitis, when this obstruction occurs, the bile can't enter the intestine and it's not available to break down those fats. So people can have fat in their poop. They can get very bloated and they can get very intolerant to fatty foods. And sometimes this, is kind of subtle, but sometimes um, somebody's gallbladder is not doing too well, and then they go eat like a super fatty meal and they're immediately in agony. So, what this looks like is right upper quadrant pain, and the classic thing is it radiates to the right shoulder. So, sometimes people have shoulder pain. Um, like I was saying, it's triggered by fatty foods, fever, nausea, and vomiting, and a positive Murphy sign. So that is what that picture is depicting. So pain on palpation of that abdomen. The way we diagnose cholecystitis is, kind of like everything else we've been talking about. White blood cells will be elevated. Liver enzymes can also be increased. And that is because the liver also produces bile and it drains through the hepatic ducts, the common bile duct, and the cystic duct into the gallbladder. But if it's not flowing through the gallbladder, then that bile stasis is going to put back pressure on the liver, and that is going to damage the hepatocytes. And remember, when hepatocytes are damaged, they're going to release those liver enzymes. So you can see elevation in those. Bilirubin can also be elevated, and that amylase lipase is elevated because the inflammation often extends to the pancreas. They all sit there pretty close together. So an ultrasound is actually the first line test. It's going to show gallstones, the thickened gallbladder wall, and the fluid. And sometimes, like just that ultrasound tech putting the probe on the stomach will be very painful when they put the probe over that gallbladder specifically. And that's called a sonographic Murphy sign. They can do something called a HIDA scan. And the HIDA scan is specific to the gallbladder. And that is just an injection where they inject radioactive dye and it travels through the liver, the gallbladder, and the bile duct. And then a camera takes a picture of what's going on. So, um, that can be diagnostic if the ultrasound is not showing it. And sometimes a CT or an MRI is useful, um, but it's more so to assess complications like a perforation or an abscess. So I know I sound like a broken record. The treatment to all these altered digestive problems are really pretty similar. Nothing by mouth, IV fluids, pain control. Somebody's going to get IV antibiotics, for that secondary infection. An NG tube if they really feel like decompression needs to occur. And ultimately, you probably know somebody who's had their gallbladder removed, or maybe you yourself have. It's not uncommon. Um, a cholecystectomy is pretty definitive. Um, After they recover, I mean, so really people can definitely live without a gallbladder because the bile will just flow directly from the liver to the intestine. But some people find after their cholecystectomy that they don't tolerate fatty foods as well. So, just something to consider. If this doesn't get treated, then it can actually become gangrenous. It can perforate, where, the bile would leak out, the pus would leak out into the abdominal cavity. That would be really bad. And somebody could be septic from this. So ulcerative colitis, this is chronic inflammation of the colon only. So not the small intestine, but the large intestine, the colon. And this starts at the rectum and it continues to spread. And this is an autoimmune illness. So a little bit about the patho. We have mucosal ulceration. This is a chronic inflammatory disease and it affects the mucosal layer of the colon and the rectum. Um, the inflammation is continuous, so it is going to, once it starts at the rectum, it extends like all the way through. Um, and what happens is that, like in other autoimmune illnesses, the body's immune system becomes overactive, but the target is the mucosa of the colon. So then edema, vascular congestion, and ulceration of the mucosa occur. The colon is normally smooth, but it gets covered with these very shallow ulcers and tissue that just bleeds really easily. And normally the mucosa is protective, but once it's affected by um, the immune system attacked, it can't protect against bacteria and digestive enzymes anymore. So then the person develops cramping, abdominal pain, and they also have just like very urgent diarrhea. The absorptive surface is affected, and the small intestine is where the absorption of nutrients occurs, but like I talked about in the structure and function lecture, the large intestine is responsible for absorbing water and electrolytes. So if the colon can't reabsorb fluid properly, then somebody's going to have watery frequent stools, and that can be very dangerous. Bleeding and pus can happen. Um, if somebody's chronically bleeding, that can lead to anemia. Um, it's really just not fun at all. So somebody is going to have bloody diarrhea, cramping. They could be going 10 to 20 times a day. Um, and the pain is typically in the left lower quadrant. And they usually feel better when they poop, but then usually that's followed by them needing to poop again. Um, Tenesmus is a word for urge to defecate, so they need to poop even when their rectum is empty. And That is because they're just living an inflamed and irritated state all the time. So this is something that can be pretty serious because this is a big cancer risk. Um, Basically, whenever you have long-term inflammation, then DNA is going to become damaged in the epithelial cells, especially if somebody's had ulcerative colitis for longer than 8 to 10 years and there's extensive colon involvement. And also, if there's a family history of colon cancer, they're just at a super high risk for mutated cells. And you can kind of see this little picture I showed the progression um, of how, under a microscope, that bottom row, it shows what can happen as those DNA mutations occur. So, toxic megacolon is something that can also occur. And this is an acute problem. The colon gets really dilated and it becomes paralyzed because of the inflammation of the muscular layer, and the colon just gets super distended and it can rupture. And there's a ton of bacteria in the colon, so we don't want it to rupture because this would be toxic for the whole body, and somebody could go septic very quickly. So if this is occurring, they may need a colectomy, and that is where they would take out a portion of the colon, or the maybe even the whole colon, and somebody would have a collection bag on the outside of their body. Diverticulitis. So with diverticulitis, this also affects part of the colon. So it's still a large intestine problem, but it typically affects the sigmoid colon. And in this case, we have the diverticula, which are small pouch-like herniation, so little outpouchings of the mucosal lining through weak areas in the muscular wall of the colon. And this creates increased pressure inside the colon. And a lot of times this is due to low fiber diets. So, working as an ER nurse, I've seen a lot of diverticulitis. A lot of times when people come to the ER and they think that they have, something really extreme with their abdomen, a lot of times it's just mild diverticulitis. And I don't mean to make light of it, but it's a lot of times it's not an emergency. It just kind of depends on how extensive it is. But I've seen it more in places where people were eating just really low nutrient, low fiber diets where they are having hard stools and they're doing a lot of straining during pooping, which is like never good to do. It can do a lot of damage. So the poop gets trapped in those little diverticulum, and then that causes local inflammation, and that is called diverticulitis. So, um, diverticulitis and ulcerative colitis, they can kind of sound similar, but that's a big distinguishing factor. Is ulcerative colitis is an autoimmune thing. Diverticulitis, it really does have a behavioral element to it, as far as how nutrition influences it. So, um, perforation is also a risk because the inflammation can spread through the wall, and then perforation can occur, but it's extremely painful. Localized swelling and infection can happen. And then you can also have little micro perforations, and you can have abscesses. So that inflammation can easily lead to infection. Typically, with diverticulosis, people are going to have left lower quadrant pain. That's the most common. So, up until now, everything we've discussed has been kind of happening more on the right side. So, this is a left left side of the abdomen pain. They can have fever, nausea, and vomiting. They can have constipation or diarrhea, and they're going to have tenderness or guarding on palpation. So, the diverticulitis treatment and diagnosis, you guessed it, it's going to look like being NPO, IV fluids and antibiotics, pain management. If there is a perforation, somebody will need surgery. So this can result in somebody needing a colostomy bag. Um, they should be trying to, once the inflammation part has passed, once things have calmed down, they should be trying to incorporate more fiber in their diet so that the poop can move through and it's not getting stuck in these little diverticula. CT scan is the gold standard for diagnosing this, and a CBC blood test will show elevated white blood cells. So that's my discussion of the exemplars. Please reach out to me with any questions, and thank you very much.